Okay, so this is probably our first class for this semester. I think. Oh, there. You can just read my name from there. It just feels so weird talking to the computer screen saying my name. So my name is Edward, and I will be your lecturer for almost the rest of 213, you could say. How exactly will this work with the coronavirus outbreak? So most likely case scenario is going to work like, YouTube videos. I also want to find out from you guys exactly how much data you have available. Should I maybe try and break down the videos into smaller segments so we can set it on WhatsApp? Do you have something like free Facebook and then we just make a Facebook page for 213 and we put everything on there? Anything like that. We don't have much of a choice. The academic program will have to go on until 14th of April, and also I think you guys will probably be very bored at home. So maybe this can mitigate some of your boredom, and you might actually want to study more. Let's say yes. Let's hope that's the case. Okay, so all of the arrangements around class I will post to you guys, and as I'm posting, hopefully then you guys know exactly what's going on in our classes. And I also I plead with you guys to make an effort and view the videos. I'm also going to put up quizzes weekly once the time actually comes. I'm going to upload the lectures as I make them, but as soon when we actually have the scheduled lectures within our roster, then I want you guys to actually go and view the videos intently, and then go and do your quizzes. Your quizzes will count participation marks. But the idea of the quiz is not really to test your participation or to just give you free marks. It really is to make sure you're actually doing effort with your own studies. It's really difficult giving class and seeing if you guys are actually following me there. You can obviously imagine it's impossible now. The only thing I'm seeing is this screen of mine, and that's it. So please, you guys will have to do effort. More about me. I think I'm in Office F5. I think that's the right code. I can't remember. Anyways, email me if you want to make an appointment. There's my email address. If you want to even make a Skype appointment, I'm available for that. I'll make myself available for that. And then if we are back on campus, if you just walk by the office and you want to ask me something, feel free to pop in, especially if I'm there. Um, I think we're on track. How my components will be structured for the semester. So I'm giving you guys rational medicine use, asthma, anemia, COPD, and dermatology. And with asthma, there's also going to be some more atopic eczema and allergic rhinitis. And there's also going to be some pharmacist-initiated care, restructuring some of the things somewhat a little bit. But of course, I'll let you know exactly as we're going along. How will it be structured? How will I actually ask these kind of questions? Well, 80%, well, this is actually handed down to us from the Pharmacy Council, but 80% of your marks has to be 80% of your quiz or 80% of your test must be surrounding understanding and application type of questions. Only 10% recall. So, if I can give you an example, what's the name of this mouthwash? Mouthwash. What's the brand of this mouthwash? Dental Mate. Okay, so that's Dental Mate. That's just recall. That's how you just remember something. If I then ask you, how does mouthwash Dental Mate actually work, or what does mouthwash Dental Mate contain that makes it a mouthwash, or I ask you something and you have to explain to me, that becomes an understanding question. And if I ask you then, if I tell you a person comes into the pharmacy with extremely bad breath, you call it halitosis. We're not worried, we're not going to actually be doing something like that. Extremely bad breath, halitosis. What would you recommend for him? Then you would have to recommend maybe a mouthwash. That will be an application type of question. I think that's a terrible example. Don't necessarily use that example. But what I'm trying to get at here is, recall-wise, you guys will have only 10% of your total marks around recall questions and easy questions, so like just remembering things. So this is what you did in your first year mostly. The rest of your marks will mostly be around understanding and application type of questions. I would also give you a few examples as we go along, and hopefully as giving you examples you would get the idea before the first test. Oh, and of course, your quizzes you're going to be doing. As you're doing your quizzes, you'll see the way I'm actually asking these questions and what I want you to carry away from from the course. Because the things I'm teaching you are the things I'll be testing as well. I kind of stick with my outcomes. Not kind of, I do stick with my outcomes. So yes, let me just take this away. I'm taking a look at the slideshow here. I can't remember exactly why I put this here, so let's just try and forget about it. Let's go to the next one. Okay, so for rational medicine use itself, should I maybe just take a small break so I can keep the video short and sweet for those who want to split it. Before we go too far, I actually remember why I have this slide here. So this slide was just trying to explain what the difference is between a recall and understanding. So if you had to recall, you can just simply, if you're looking at this little mind map I put here, look at this mind map, you'll see there's a bunch of different terms here, like cyclooxygenase, COX, lipooxygenase, LOX, NSAIDs, theophylline, caffeine, bronchial. Anyways, all of these terms are remembering, so you have to remember these terms. The way these terms influence each other and the way they interlink with each other, you require an understanding for that. So if you think about a mind map, all of these different lines connecting different aspects or different components is actually like the understanding section of the work. So I'm more concerned in the modules I'm teaching about the little lines and how they connect to each other than I am concerned about the names themselves. Or actually, I'm lying. I'm concerned about both of them. You have to know the little names before you can link them together. So if you are getting towards understanding your work, you have to anyways remember your work. And especially in pharmacology, it's very much content intensive, so there's just so much work, and I think you guys have already experienced that with your autonomic nervous system, so I don't have to kind of hammer on that so much now. That's a good point, so we can go on. For you guys today, we're talking about rational medicine use mostly. Rational medicine use itself is probably the most important thing for a pharmacist in South Africa, or the most important thing you're trying to protect or trying to adhere to in South Africa. Everything centers around it. The fact that the pharmacist is employed in a pharmacy, the fact that you're checking prescriptions, the fact that you're following guidelines, all of that links back to rational medicine use. This is one of the main reasons why you're trained. This is probably, in my mind, can't really say that, but one of the most important aspects of being a pharmacist is adhering to rational medicine policies, rational medicine use. So, outcomes for rational medicine use itself. Describe rational medicine use, yes and yeah, okay. So if you're just describing it, you're basically just telling me about a definition, for example, so that's a recall kind of question. If you apply rational medicine use principles to patient case studies in dermatology, asthma, COPD, and anemia, then you are, well, there's application kind of questions. So I would, for example, I can give you a prescription for asthma treatment that's completely incorrect, that the patient might actually get an asthma attack from. And then I could ask you to decipher what went wrong there, and that could be a way I'm testing if you actually understand what the rational medicine use is by applying it to a case. Remember, as we're doing pharmacology from second year, third year, fourth year, pace, all of it, as we're doing pharmacology, you will, in a certain sense, indirectly always be tested for rational medicine use, because we always want you to adhere to the best possible treatment for a patient. So the best possible treatment for a patient is rational medicine use, in a certain sense. List reasons for irrational medicine use. So if you're listing things, we're just recalling it. List dangers of irrational medicine use. Once again, same thing. What about the future? I'm also mentioning this because when you guys actually end up in your fourth year and you have to choose your elective, it's probably important to choose the right elective. So, what is South Africa's expectations of pharmacists for the future? And there is a spelling mistake there. Let me just delete it. What is the future holding for us? So, if you want to be a pharmacist employed in, what do we call it? Employed in government. Government is probably where most of us would want to be employed. If you are employed in government, you would be earning a very big salary. It's somewhere around there. I hope you can't see that number. It's actually absurd. I don't think we should earn that much money in government. Well, it depends. That's probably a very, very controversial statement. But anyways, if you want to be earning that money in government, you have to do ABCD. ABCD are the core skills and expertise a pharmacist needs to have to actually be employed in government and work in government, all centered around rational medicine use. Clinical expertise around rational medicine use. What do we call this PTC meetings again? PTC is the pharmacotherapy committee. It's not pharmacotherapy, it's the I think it's the pharmacotherapy committee involvement. I think it's referring basically to that little committee that sits together and discusses patient cases and what's the best medicine to use. So if you're discussing with a doctor and nurse and etc about best medicine to use, already again it centers around rational medicine use once again. Procurement, financial management, okay, we're skipping that. That's probably more pharmacy practice. Medicine quality and safety, pharmaceutics. Health and pharmacoeconomics, that's pharmacy practice once again. Antimicrobial resistance. Why do we even have antimicrobial resistance? And that is mostly because of irrational prescribing. So non adherence to rational medicine use policies, or non adherence to rational medicine use guidelines. Infection prevention and control. Well, you can see why it's so important now in Corona 2019, of the COVID 2019 case. If we could just have prevented so many infections, we could have prevented doing electronic classes like this. And there you can see on top, rational medicine use. But I want you to also see how it interlinks with all of these things. Rational medicine use is core to being a pharmacist. And of course, evidence-based medicine is what guides rational medicine use. So, if you want to be employed in South Africa's government and you want to be a pharmacist, or just basically if you want to be a pharmacist, pharmacist working in a communities, etc., rational medicine use should be one of your primary things on your mind with every single patient. You must always be thinking about what is the best medicine for this patient. Can I do something better? Is there something I should change? And as we move with you guys through the years, when you get eventually to PACE, we're making pharmaceutical care plans, and those care plans are in essence trying to find out what is the best medicine for this patient to get the best outcomes I can for him. And all of that is also centered around evidence-based medicine, which is a part of rational medicine use. I think I've I've highlighted enough why it's so important to you guys understand rational medicine use. Let me just take time again. Time flies when I'm talking to the computer. I don't know why. Okay, break time. Okay, so what does rational actually mean? I think this is just a Google search I quickly did. And based on or in accordance with reason and logic. Awesome, isn't it? So, if you think about it, how do we even know medicines work? How do we know that if I give you, for example, amoxicillin for a dental abscess, how do we know it's going to work? Even if you know the pharmacological mechanism of the drug, how do we know it will work specifically on that bacteria causing that infection? And the only way we find out these things are through trials, so clinical trials. When we do clinical trials, we find out, we create data, and from that data we have to make a conclusion. And if we have large-scale data, we create strong evidence. As we get strong evidence, it basically tells us what is the right decision. So if you look at synonyms there, reasoned, logical, the logical conclusion or the logical conclusion you should make from large-scale data that says ABC is the truth is that ABC is the truth. Logically, ABC should be the truth then. So if I have to put this in context of amoxicillin treatment in dental abscesses, then I know that amoxicillin works in dental abscesses. Of 90% of the cases, all responded very well to amoxicillin usage in dental abscesses. Then I know that I've got 90% of the cases are actually treated well with amoxicillin. Amoxicillin is a viable option to use. If I was comparing amoxicillin maybe to something else like metronidazole alone, and metronidazole only caused the response in 20% of patients, then I know logically I shouldn't use metronidazole, I should use amoxicillin. And this is what evidence-based medicine is really about. It's about taking all of the data around the world, compiling it and finding the right conclusion, and then using that to reason or to create your guidelines or treatment guidelines. And I hope that's making sense so far. So if you just look at all of these little synonyms here for rational, enlightened, and enlightened is my favorite one. Intelligent, sound, sober, prudent, astute, shrewd, just studious. Anyways, all of these are just referring to actually knowing what you're talking about. Enlightened is my favorite one. Do you think a person who doesn't have pharmacy education would be able to actually advise anyone else on rational medicine use or pharmacology or pharmaceutics, or maybe the stability of a drug? Probably not. So the first step of becoming a rational medicine use expert is actually in being enlightening yourself or becoming enlightened. Once you are enlightened, you can actually start making the right decisions, but first you have to get the right education. That's why you're listening to me now, or that's why you're in PhD 213. So good step. And I think I've kind of described what rational means well enough. A little definition here from the World Health Organization. Rational use of drugs require the patient receive medication inappropriate to their clinical needs in doses that meet their own individual requirements for an adequate period of time and the lowest cost to them and their community. So in essence, if you take that and you break it down, you're getting these 5 R's. The right patient, the right diagnosis, the right time, the right dose, via the right route. And then we didn't actually have money in here. Anyways, the right patient, the right dose, the right route, the right dose. Where's the right drug? Wait, 1, 2, 3, 4, 5. Oh, okay. I don't have my drug here, but of course the right drug should be a part of it. So just put another R in there for the right drug. Anyway, so these 5 R's are basically the basis of all rational medicine use. And I'm gonna use a lot of what do you call it, examples, and I'm gonna center them around, let's say, patients with corona or COVID-19 coming to a healthcare practitioner and getting a prescription, or going to a pharmacist, or no, we'll see exactly how I'm going to structure them. So where does all of this start? It starts with enlightenment. I think I just said it. Only through learning and understanding can we actually decide what is right. So only through evidence can we decide what is right. Why do we not just, for all people with corona or COVID-19, give them antivirals? Because we simply don't know if it will work at this moment. We can actually, on a pharmacological basis, already see that some of them might not work, and then by actually testing them in patients, doing clinical trials on patients, can we find out if some of them will actually work. So at this moment, we don't actually know which ones would work, so we have to become enlightened first. And the only way to become enlightened is to actually know what the drugs are that we have available. So you guys are on your way to finding that out. As you find this out, then you can make the right decisions. The healthcare team working towards, okay, so where does it start? Okay, the healthcare team, of course, we're working in a team. You guys are dispensing a prescription, but you're dispensing a prescription based on a diagnosis that was made earlier. If the diagnosis was wrong, and you can see that from prescription, or the diagnosis was right, but the prescription, the prescribed medication is the wrong one, maybe, we can actually prevent irrational use of medicine. So if you're educated well enough, you will make the right decisions. They must follow a logical and objective approach. So patient has hypertension, patient gets prescribed first-line therapy, patient receives first-line therapy, patient gets retested. After getting retested, patient is adherent and things are going well. So there's a logical approach to all patient care. Or there should be a logical approach to all patient care, and it should always be objective. There must be something you want to achieve when you're giving a patient a drug. You're not giving anyone a drug just for willy-nilly reasons. There must be a reason why you're giving a patient a drug, and that the reason you're giving the drug you must be able to measure if you're achieving what you want to achieve with your drug. So when a patient has a healthcare-related complaint, where is his first stop? And now I have this little button here. Let me just quickly take a small break again, and this is probably going to take an hour to make your video, but hopefully you guys actually view it. Then I'll be happy. Okay, so I was thinking, since we are in the coronavirus pandemic, let's just make sense of where things could go wrong in the terms of rational medicine use. So let's quickly look at a patient who recently visited over Tambo International Airport, or maybe Cape Town International Airport. They go to a doctor, and then the doctor sees them and he inspects them, and he says, no, this is just a normal flu, you can go home, there's nothing. Oh no, this is just a normal flu, I'm going to prescribe to you something like an antibiotic. He prescribes an antibiotic, the pharmacist sees this person, the pharmacist actually dispenses it, the patient adheres to treatment and he doesn't improve, and then he goes back to the doctor. Where did the mistake happen? If you think about it, where did it happen? Well, probably in the very first case. So in the first case, there was a viral infection. So if it was in a different time, not now, then we could have said it was a viral infection, there's no treatment for it, we just continue. But in the first case, that patient, because the viral infection, a flu, a common cold, and coronaviruses are so similar, and we have been handed down what's the right word for this? Instructions by the government to actually test all of these patients. The first mistake that this doctor made was not testing this patient. So this patient wasn't tested. So he didn't actually even know he has to be quarantined. So now he went around different people. He never got instructions to quarantine himself. Now he's infected different people as well. So that would be an example of irrational medicine use from the very first get-go. And then it gets worse, because this doctor actually prescribed an antibiotic for a person who has a viral infection, which is completely inappropriate. There is no antibiotic that treats a viral infection. Yeah, there isn't. No, there's nothing. So he was prescribed the wrong antibiotic. So it would never have worked anyways. And now he's running around to all of these different healthcare providers, putting everyone at risk for no reason. So first part that went wrong here, doctor was unenlightened, doctor prescribed the wrong drug, and even he didn't even test the person. So that's complete, craziness. And it's probably happening at this very moment in South Africa. Let's hope not. Let's hope I'm wrong. Okay. So then he prescribed the wrong drug and then dispense. So then the pharmacist looked at this and he saw, oh, it looks like you could have corona. Like, I mean, you've got the cough and you've got everything and you've been prescribed an antibiotic. Did you get the test? And then the patient says, no, he didn't get the test. And at that point, alarm bells should be going off. And you should probably notify the NICD that this person actually could have corona and he wasn't tested. And he's being prescribed antibiotics. But he shouldn't be getting antibiotics. Anyways, so I'm just showing you the way we should actually intervene. In this case, you should have intervened for sure. Anyways, let's say you're a retarded pharmacist and then you dispense these antibiotics anyways. Patient gets it, patient adheres to it, he's got no instructions to stay at home, he's been told it's just a normal flu, he goes around, he infects 15,000, not 15,000, he infects 15 more people, and those 15 people go on to infect more and more and more people until we actually have a complete breakdown of our healthcare system. All of this here could have been avoided, and if you think about it, the big place to avoid it was with diagnosis and the follow-up. So the very first case, the diagnosis itself, should have been made right. So if the doctor didn't know the right diagnosis, we could have 1,000 problems following. But then also at the dispensing part, when the pharmacist is dispensing it, we could have stopped this whole process as well, and we could have prevented further spread of the virus. Is it making sense? The medicine use circle, and it's also like a domino effect. The less education is in that circle there, the more problems will follow. Okay. I think let me just quickly stop there. I think that explanation, I think that's a nice, fine explanation at least. We'll go into some small details and we'll see. I think I've already discussed these in a certain way, so we'll see if I actually go over them again. Pause. Okay, so if you look at step 1, so we're basically talking about the circle still. We're just going to break it down a little bit more. So step 1, we're talking about the first point of entry. It could be a pharmacy, it could be a doctor's consultation area, it could be a nurse consultation, however. So when you see the patient the first time, I mean, you don't know what's wrong yet. You have to actually get an accurate diagnosis. Only when you have an accurate diagnosis can you move on to the next step. So we also have PCDT pharmacists, so it also involves us to a big degree as well. Can you just think about it? If you don't have the right diagnosis, do you think you'll even get close to the right drug? Never mind dispense the right drug. I mean, there's just no way. So without the right diagnosis, you just cannot do the right things next. You cannot find the right drug. You won't find the right dose. Even in some cases, the dosages might differ for different indications. So if the indication is based on diagnosis, so if you don't have the right diagnosis, you have no chance in succeeding the rest of the way. And then you choose the safe and effective treatments, and this is based on a bunch of different things. Let me just give you an example here. In South Africa, we have the standard treatment guidelines, and this is used in conjunction or in this is used in combination with the essential medicine list. And the essential medicine list is, in essence, a list of drugs that are must-haves in South Africa for all of our diseases that are pertinent or very high up, very pertinent, very common. Oh my word, I can't believe I struggled with that word. Very common in South Africa. So these are drugs that are very effective in the treatment of the most common diseases in South Africa, that are cost effective, so I mean they don't cost an arm and a leg, and they actually have proven benefit. And it's not like the South African government is stingy by any means with these treatments. The South African government, even there was a approved drug just the other day called basliximab. So basliximab is approved for renal transplantations. I think that's 8,000 rand for 2 tablets, and the government improved it because it gave a 3% reduction in acute organ rejections. So that is considered enough evidence to actually approve that drug for inclusion in the EML and for use in the South African treatment guidelines. So I mean, South African government is not stingy. It just needs enough evidence to back up the reason for the costs. So if the reasons justify the costs, there's definitely reason to actually include it in the EML. Um, Mentioning this because I don't want you to think that the South African government is cheapskates. Not at all. Medicines don't necessarily have to be very expensive to be effective. It's a complete myth made by private corporations. In a lot of cases, if you compare something like enalapril to losartan and etc. No, enalapril to perindopril and they all fall in the same class, but all of them are just released by different companies, and then uh, they would actually be promoting those products. Well, we won't actually see that per se, or there's not actually on a piece of paper that actually say promoting those products, but they're probably promoting it in some way or another. And they would promote these products as better, but they're not really better at all. So if we look at that enalapril and we compare those in randomized control trials, we can see enalapril is better or even more effective than the newer ones coming out. So then why would we ever include the newer ones? They cost more, but enalapril is effective. So no, we won't. We just throw away that one. We keep enalapril. And that's literally what we do. And that's how the medicine list is compiled in South Africa. And it's also the cheapest way to do things, in a certain sense. This is a very big conversation, also a conversation I just quickly want to have in rational medicine use. As long as you guys understand at this moment that the EML is based on rational medicine use principles, and that includes, well, the most common disease in South Africa, and also uh, the most cost-effective treatments, if based on also the evidence behind the treatments. Okay, I hope that's making sense. Now, pinpointing okay, so we are going for 3 steps here. The first step is still diagnosis. The second step was choosing between different treatments. Now we're looking at the the actual drug itself, the correct dose, the correct route, every etc. All of this is also once again based on evidence. If we have a randomized control trial and we compared, for example, intramuscular injections of, what can we use? Voltaren. Let's use Voltaren. Voltaren intramuscular injections once a week or once every 3 days versus Voltaren tablets. And we got the evidence back, and the evidence showed that there's such a big risk for actually getting an abscess when you inject the Voltaren versus just taking the Voltaren orally, that it doesn't justify the risk you're taking, and that oral medication is most likely better. I just mentioned something at the end here. This is another good example. If a person is in a hospital and they have a pneumonia, not a COVID pneumonia, we don't have a treatment for a COVID pneumonia yet, but if they have a pneumonia like a, let's call it a streptococcus pneumoniae, strep pneumonia. If they have a strep pneumonia, bacterial infection causing pneumonia, should we treat them with an IV antibiotic because this is a severe infection, it's a severe disease to have, or should we give them oral antibiotics, oral amoxicillin, or should it be IV amoxicillin? And then it makes much more sense to give an oral medication in this case, because if the patient gets an IV one, they have to stay in hospital. Staying in hospital increases your risk for a bunch of different infections and a bunch of different problems, nosocomial diseases, which would not happen if you just take the oral antibiotic. And if we compare the bioavailability of the oral tablet is high enough to say that we don't need the IV medication. And then if you actually take a look at the outcomes in 5,000 people, for example, we can say that, we can see the data and we can draw the conclusion. The conclusion says that oral treatment of amoxicillin is superior to IV treatment with amoxicillin in community-acquired pneumonia based on all of these different outcomes that we measured. That's how we basically create our data. Okay, so we pinpointing the actual right drug, the right dose, the right route, etc. Step 4, this comes monitoring evaluation. So we gave that antibiotic in the previous step because of bacterial pneumonia. So now we have to also see, is it working to decrease this bacterial pneumonia? Is the person's respiratory rate coming down? Is his infection markers coming down? Is he improving? If it's not improving, then we know amoxicillin wasn't the right choice. So even if the evidence might have said 99% of cases it's the right choice, this might have been that one case that's not the right choice, and then we have to reassess the situation. But of course, whenever you're giving a tablet, you're giving it for a reason. How would you monitor the effectiveness of paracetamol, for example? Well, what are we using it for? If you're using it for headache, a reduction in pain. So if a person tells you his pain is 8 out of 10, and after using paracetamol is now 3 out of 10, then you know it's somewhat effective. How would we monitor blood pressure medication? If I give you something like enalapril for your blood pressure, and your blood pressure goes from 140 to 120 over 90, then we know it's working. Or if it doesn't go down, then we know it's not working. Antibiotics, I just gave you an example. Okay, so I'm going to go over case now, but let's just take a quick break. Okay, so this case that I had here is basically about a patient who had a blood pressure of 165 over 109. He was taking enalapril 10 milligrams, hydrochlorothiazide 12.5 milligrams, atenolol 50 milligrams, and amlodipine. All of those once daily, I think. Yeah, all of them once daily. And then the dose was increased to 10 milligrams BD, 25 of enalapril, 25 milligrams daily for hydrochlorothiazide, atenolol 50 milligrams BD, and EDC. And then in the follow-up, the blood pressure was still high. So if you're looking at this circle again, where did the mistake maybe happen? So diagnosis was accurate. This patient had blood pressure. Prescribing itself, probably yes and no. It seems like the right thing at the moment. Dispensing wise, I mean, you won't really know. So yes and no. Patient adherence. Oh, do we know if the patient was adherent in the first case? Did we maybe just give a lot of drugs to this patient without knowing if this patient is adherent? Maybe it's possible. So maybe when we prescribe all of these extra drugs, we don't actually know if the patient was taking it. So all of these new drugs that we prescribed might have been completely pointless. Not pointless, just unnecessary. So we have to find out if she's adherent. So this was a case I was explained by one of my professors back in the day, and then he forced her to bring her all of the medication to the pharmacy, and when he checked her drinking her medication, her blood pressure fell dangerously low actually. And then we could safely say that adherence was the issue. And I'm making this statement here because it's very important to know that the general population struggles so much to stay adherent. So even if we follow all of the rational medicine use principles, we get all of the right drugs for the right patients, for the right indications, right everything, we still have to double check that they actually take their drugs. So I think this is American data. It's also very old American data. But it says here, for example, that for every 100 prescriptions written, 50 to 70 are filled. So that means like 30 to 50 people just don't actually fill them. And then of that 50 to 70, 48 to 66 are picked up from the pharmacy. So some of them actually fill it and don't even pick it up. And then 25 to 30 of the original 100 are taken properly. Wow, we've lost a lot of people here. And then only 15 to 20 prescriptions are refilled. So if you think a person with hypertension here, or a person with dyslipidemia, or any of those kind of chronic diseases, their long-term outcomes and risks for complications 100% correlate with them taking their drug at the right time and interval. So if a person isn't adherent, do you think we'll achieve good things, good outcomes? Probably not. And yes, people generally are not adherent. You'll see that more and more as we go through the work here. So of course, if you want to also know what a rational drug uses, you have to know what irrational drug uses. So think about the incorrect medication according to diagnosis. So you have a right diagnosis, but you're giving the wrong medication. Or you have the right medication. No, I can't go the other way around. You can't have the right medication if you don't have the right diagnosis. If you don't have the right diagnosis, you won't know if you have the right medication. Utilization of an invasive route when not required. So if a person could be treated with an oral drug and they actually get an IV drug, why are you actually doing the IV drug? You're just increasing the risk for infection again. So always go with the oral route if you can. Unless you can't, then of course the IV route is amazing. Use of medication absent diagnosis. That's just abuse. Why would you use medication if you don't have a diagnosis? Oh, like addiction, for example. Unnecessary combinations. Of course, I mean, if you the less drugs you use and you still achieve the same outcome, why would you add more drugs? The more drugs you add, the bigger your chances of actually inhibiting or inducing an enzyme, the bigger your chances for drug-drug interactions. Expensive treatment where more affordable, equally effective alternatives exist. So this in South Africa happens so much. If you're working in a community pharmacy like Clicks or Dischem or any of them, you'll see a lot of prescriptions come in for Nexium, and then the doctor says no substitutions, even though there's a lot of data that says omeprazole is comparable to lansoprazole in effectiveness. There's actually no difference, but still people want that Nexium because they think it's more effective. That's a certain type of bias, and if the evidence says that there is no difference, but you adhere to that expensive one because you think it's better, that means your bias. So sticking to expensive adherence where affordable options are available, very irrational. Especially in South Africa, you're just making people poor and some company rich for no good reason. The use of medication for cosmetic purposes, well, of course. Think about Botox. Anything opposite of the 5 R's basically is what constitutes irrational drug use or irrational medicine use. What is the dangers of irrational drug use? I think a lot of that should be obvious, but I'll just go over a few examples here. High possibility of adverse events due to unnecessary exposure to a drug. So if we use 2 drugs to treat blood pressure and 2 drugs were effective, we don't check the adherence of the patient and we add another 3 drugs. Those 3 drugs cause a drug-drug interaction, and that drug-drug interaction leads to the patient becoming hospitalized maybe. That's a very bad, that's an example of how irrationally giving the drugs together before actually checking if the patient is adherent could lead to an adverse drug reaction. We already have a nice example about with the increase of drug resistance. This is especially prevalent with antibacterial drugs. So you'll see in the antibacterial drugs there's a lot of drug bug resistance or bug drug resistance. Well, there's a lot of microbes that are resistant to the treatments we're giving them these days. And it stems from the irrational use of antibiotics. Giving antibiotics for everything from flu to, well, you can name any, giving antibiotics for a bunch of diseases without a clear indication, or without the right indication or right diagnosis. Of course, unnecessary costs. Why would we want to have unnecessary costs if we could get the same thing done for cheaper? Reduction in quality of life. If you're taking 15 different medications, we could have just had 5. Now you maybe can't drink your pomegranate juice anymore, and you're very unhappy about that. Increase the risk for adverse events. The more drugs you're using, the more likely you can get the adverse event, of course. Ineffective treatment, re-evaluation, retreatment. I mean, you're going through the cycle again. Now you have to go back to the doctor and you have to restart the cycle. If you just did the right thing in the first case, it might not have happened. Or maybe you're going to one doctor, now you have to go to a different doctor because this doctor didn't know what he's doing. To give you an idea, patient distress, prolong of disease. Okay, so factors that can actually influence prescribing, and I put this here because most of the irrational drug use stems from irrational prescribing. That is the biggest contributor to irrational drug use by far. If we look at the circle here, lack of training. Well, we know that pharmacology is a difficult module. You guys also know that. So what if they just simply weren't taught? If they weren't taught, how would you expect them ever to have the right drug, to prescribe the right drug? Poor role models. So you'll also see that in some state institutions. I haven't worked enough in private institutions, so I can't say for sure. There would be one doctor who is very adamant about the use of ibuprofen for this patient, or one doctor who is very adamant about the use of paracetamol for dropping fever in all patients. Then everyone just kind of copies what he's doing because he might be the consultant, he might be the higher up in that ward, and then they simply adhere to what he does. Even though there is evidence that says there are better options, he doesn't actually do it. So the patients or the interns maybe working beneath that consultant are just too scared of him, so they just stick to what he's doing. Inadequate information, maybe they just don't know anything better. Financial interest, of course. I mean, if you get a financial interest, that's definitely the worst possible thing. So same for a dispenser, same for us, a pharmacist. Poor training. If you didn't know about corona and you treat all corona patients as flu patients, I mean, you're contributing to the problem. No supervision. So I think this refers to pharmacy assistants. If you don't actually supervise what they're doing, they might do the wrong thing and give that antibiotic to a person who had a viral infection. Shortage of materials. So not having enough stock. If you don't have enough stock, you can't actually give the drug. So if you can't give the drug, it also constitutes, well, not having the drug, and you're not actually treating the disease. So that's also irrational in a certain sense. Patient load. Patient load really refers to information. If a patient is getting an asthma inhaler for the first time and he's never even seen anyone take an asthma inhalation, and the pharmacist just gives it without giving an explanation of how it works, he won't be adherent. There's just no ways. Or even if he is adherent, trying his best, he might not actually have the right technique to get enough drug into his lungs. Then of course he's going to come back. Patient and community. Lack of printed information, prescriber attitudes, short consulting times, available funds, cultural beliefs. All of this is, I think it should just make sense. Health supply system, medicine shortages, unreliable supply. All of this is in South Africa that's contributing. expired, substandard, and counterfeit medications. I don't think we have so much substandard in the essential medicines of South Africa, so I wouldn't even give this any thought really. But expired, I would definitely give some thought. That happens a lot, and that happens because of malmanagement. Wrong medicines. Well, wrong medicines kind of fall into the dispenser's world, so you shouldn't give the wrong medicines, or shouldn't give the wrong medicines if something else is prescribed. And it also goes with the prescriber. If the prescriber is prescribing the wrong thing, of course. And then I want to talk about antimicrobial resistance, but I'm going to give a small break because I see I'm starting to talk faster and faster and faster. Typical of me. Very typical of me. Okay, so I think I've ranted enough about this circle. This is maybe just an easy way to look at it. I have some few more slides explaining why it's so important, or how we actually do the irrational things, or things that lead to irrational drug use. In a certain sense, to understand why it's so important to make sure everything is rational, or we actually use drugs rationally. The easiest example I can think of is antimicrobial resistance. So eventually, the leading cause of death in the world will most likely be antimicrobial resistance, because every single time an antibiotic is used erroneously, or used for the wrong indication, or used unnecessarily, we actually contribute to bacterial resistance. So eventually it's going to be our main driver of disease, or main driver of mortality within the world. So I'm just putting this one out here to give you an idea. I mean, there's even more deaths per year than cancer. So this is coming, and eventually it will be one of the main things. Maybe we can still avert it. Maybe there's still some time left. But this is one of the estimations at the moment. Okay, so I've already, in a certain sense, gone around that little circle and tried to explain a little bit of it. But here's a little, maybe a bit different explanation for you guys if you want to make sense of what drives irrational drug use. So patient pressure. If some moms and maybe some dads as well, probably some dads as well, they actually go to a doctor with a little child, and this patient has a cough, and they would tell this doctor, no, you have to give me antibiotics. I'm not going out of this office without antibiotics. And then it's so uncomfortable in that office, the poor doctor just gives into the social pressure, and then he gives the cough, and then he gives the antibiotics, and then the patient leaves. He also fully knowing full well it won't work, just gave in to get rid of that uncomfortable situation. So patient pressure is definitely a reason. Poor training. I mean, if you don't know, you can't use a bacterial you can't use an antibiotic for a viral infection, then you don't know, and you think you're doing the right thing, you think you're doing an amazing job, but you just had no idea. Prescriber irrationality. So I think this mostly goes with marketing. Inadequate staff for sure as well. If you have to run around like a crazy person the whole day, staying on top of things, if you have so much work to do, it's just unlikely. And that's also why I plead with you guys, while your students do a lot of effort, it becomes more and more and more difficult when you finish university to actually keep up to date with what's going on. Lack of communication between different role players. I think about the PTC meetings, and yeah. Anyways, non-adherence due to inadequate knowledge of patient. If the workload is very high for a pharmacist, the pharmacist could have all the right scripts with the right diagnosis, but if he only has 2 minutes per patient, and that's from getting the prescription to actually dispensing the prescription, what's the chances he's going to actually counsel that patient appropriately? Wink, wink, nudge, nudge, clicks. Anyways, I'm mentioning this because if you don't inform your patients well enough, how could you possibly expect them to adhere to the medications well enough? Promotional activities for companies. I can't think of an example there now. Role models, like I gave you an example earlier. If the specialist in a certain ward of a hospital does something irrational, but he pressurizes, or just the fact that he does it makes other people also start doing it, is an example of following a role model that's doing something illogical, but he has the title, so it in a certain sense forces everyone else to do the same thing in the hospital environment. Remember, it's a very hierarchical system, so if the topmost guy does it, everyone below also starts doing it. Illogical thought process. Anyways, what can we do to assess irrational drug use patterns? Implement regulatory constraints, so we can ban the use of unsafe drugs like codeine. We can schedule drugs so you can't actually get to them unless you have a prescription. We can train healthcare providers, and this is my favorite one. Training healthcare providers is where everything starts. If you don't know you're doing the wrong thing, how could you expect a person to actually change that behavior? So the Pharmacy Council is now forcing all pharmacists to do CPD training. I had to do CPD training this year as well. I continually do it, but I had to do it this year as well. So continual professional development refers to getting new information, staying up to date. So if you go for workshops and courses, presentations, etc., you get the new information, you stay up to date, and then you make the right decisions, the right choices. Avoid perverse financial incentives. So back in the day, there were actually cases where the doctor who prescribed the most, let's use, I can't use an example now because then I'm implicating some company, but if a doctor used, for example, drug A, no, there would be a competition between all the doctors in a certain region, unofficial competition, of course, and drug A was maybe the one they had to prescribe the most. If Dr. ABC prescribed drug A the most in that region, he would win a trip to Hawaii, and then he would then, of course, want to prescribe the drug unnecessarily for everyone. So there were actually things like that happening, especially in America, as far as I remember. Implement standard operating procedures at managerial level. So the implementation of essential medicine lists, so only the drugs that are that have a lot of evidence behind them, and using a standard treatment guideline. So your diagnosis is based off facts. I'm going to give you examples now how that's going to work. So how South Africa is doing this, and this is why I want to give the examples now. We are trying to adhere to, well, we are trying to implement rational medicine use, or we are trying to not implement, we are trying our best to adhere to rational medicine use policies by implementing the essential medicine list and the standard treatment guidelines. And we have 3 different levels of this: primary healthcare, which is clinics, secondary hospitals, such as hospitals, and then tertiary and quaternary, which refers to specialized hospitals like Tygerberg, and teaching hospitals. Not necessarily teaching hospitals, but yes. And all of these, we have essential medicine lists there. So the essential medicine list is compiled through affordability, cost effectiveness, efficacy, and quality. And all of this comes from evidence. So all of it must be an evidence-based approach followed to include drugs in here. You can't just want to include a drug and get it in there. You actually have to present the evidence to get the drug approved for that EML inclusion. And this list is made so we can address the needs of the majority of the people. So the most common diseases in South Africa. And how do we assess the evidence? We look at our there's a little rubric for it here, not a rubric, a little pyramid. Very much oversimplify this. If you want to know more about this, in the 4th year, choose rational medicine use. But we start at the very bottom here. So case report. So if 5 patients recovered by using, maybe let's do this. Let's compare the use of paracetamol and the use of ibuprofen in headaches. So one doctor could tell you, but ibuprofen always works better than paracetamol in headaches. That constitutes an opinion. It's not even an expert opinion, just an opinion. Even if a specialist tells you that ibuprofen always works better in headaches than paracetamol, it still only constitutes an opinion. It doesn't constitute anything more. The expert opinion is a bit mixy. The expert opinion can also go on top here, but I'll tell you guys why just now. Then a case study. So if 10 patients were given paracetamol and ibuprofen each, so 5, and then all 5 got better treatment outcomes with ibuprofen, that could constitute level 4, for example. Or if we had 10 patients and all of them received ibuprofen and all of them responded well, we can say that's a case series, and we could take that as a level 4 evidence. And then a case control series, if we can control the patient's ages, and we can control what type of headache they had, and we can control the dosage of paracetamol all of them had. You can use it as a case control series. A cohort refers to thousands of, not thousands, but just a large amount of patients we follow for a long period of time, also in a very controlled environment. And we see that as we're giving them ibuprofen, they are responding well. That constitutes a cohort in a certain sense. A bit more complicated than that, but just to give you an idea. And at the very top, we have the gold standard, the randomized control trials. So if we're comparing one drug to another drug, so if we compare paracetamol to ibuprofen in 600 patients, 300 paracetamol, 300 ibuprofen, all of them are similar ages, they all have the same type of headache, they're all taking the same dosages on the different groups, and there's not a lot of variables that can influence our results. And then when we get the results back, we can clearly see that paracetamol was actually working better. Then we can say, but no, this expert opinion is most useless. We know that paracetamol works better in that certain circumstances, and that constitutes our highest level of evidence. So normally, for any inclusion into the EML, we really want this randomized control trials to guide decision making. In government, we also have the same kind of grading for it. It's a bit more complicated, but I'm just giving you an idea there. But still, if we have the right drugs and we include the right drugs in our EML, that's not enough. Because remember, where does all irrational medicine use start, or where is the biggest possibility for irrational medicine use to start? Diagnosis. So, to limit the amount of misdiagnosis or inaccurate diagnosis in South Africa, the South African government has created the standard treatment guidelines. Okay, but this is also actually something that's been there for quite a while. The World Healthcare Organization, I think, started it. But it is basically a guideline on how to make a diagnosis. So, not how to make a diagnosis, but a guideline to ruling out everything else and getting the specific diagnosis. I'm going to show you an example in just a second here. Okay, so this standard treatment guidelines has a lot of advantages. It gives you a standardized way of actually standardized way for all practitioners to follow. So we have a standardization across the board for all practitioners. It encourages prescribers to make use of the EML. So all the standard treatment guidelines in South Africa would advocate for a certain drug to be used in a certain condition. So the first option drugs are all EML drugs, so the cheapest possible drugs in South Africa. And it enables people providing care to a patient to concentrate on the correct diagnosis, because everything else would just fall into place if they follow this guideline. So here's a nice example for you. A person has a fever, and now how do you actually go down this list? This was a patient who was maybe in Mozambique a while ago. So he had a fever, he's presenting other symptoms of malaria. So now you have to assess him. Is it a cough, sputum, sore throat, skin rash, anemia, etc.? And now you say no, or you say yes. You treat the cause. Fever persists for more than 48 hours? Yes. And then you get a malaria test. You do a malaria test. Malaria is positive, you treat the malaria. Condition improving, not improving, and refer the patient. So I don't really want to go into malaria, for example. I want to go into the logical thought process that would guide you in making decisions for this patient. So remembering all of the information for everything is impossible. You need a standard treatment guideline to help you remember all of the information. As you get experience and you follow this guideline, eventually you probably know how this guideline is put together. But just knowing all of the information intuitively is no ways. So we need these kinds of logical thought processes in the standard treatment guidelines to help us. So this is an easy way of making the right decision based on evidence. So all of these steps here are based on evidence. So this here you can see a fever persists for 48 hours. If the fever doesn't persist for 48 hours, we know it's most likely not malaria. So then we don't do anything. But if the fever persists for more than 48 hours, we know, oh my word, that's very likely malaria. So let's test malaria. Then we test malaria, and then it's negative. Oh my word. Okay, we're making progress here. Does that make sense? I hope it's making sense. Oh, I do have a few more examples. But at the moment, I hope it's making sense to you how the standard treatment guidelines work and how the evidence-based EML essential medicine lists work. When you use your apps, your EM guidance apps or your EML clinical app, that is basically your standard treatment guidelines, and all the drugs that are advocated for use or prescribed, all of the drugs that are there. So if you have, for example, HIV, the treatment options in there all stem from the essential medicine list. And then we can almost move on to the last little example there. I just had this slide here. It's not really important for you guys to know this. I just want to give you an example. How does the government actually get these things done? But I think you can just read through it. It's not important to know. I'm just a big advocate for the way the government actually gets prices down so much. So that's why I put this little slide here. And I have one more example here I'm going to go into. But I think a small break first. Otherwise I'm just going to tire you guys out. You're probably tired already. Okay, last little example. Just quickly run through. So here we have a patient blue 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 or blue blah blah. An asthmatic patient. This patient prescribed systemic glucocorticoids, 10 milligram prednisone for the treatment of asthma, 6 months per repeat. Patient was previously only taking salbutamol. Draw a logical flow chart on the board behind you. Oh, this is actually for me when in class, so I can't do that now. For the class and using the email clap, enlightened Dr. Blue. So the problem here actually started with the doctor prescribing the wrong drug in the first case. So the logical flow chart is something like this. We're going to go into asthma a lot more later, and then you can actually tell me what inadequate control means. How do we actually determine inadequate control? So, but the logical flow chart is something like this. Treatment flow chart, asthma symptoms, you start with salbutamol. After you get salbutamol, you most likely are fine. Well, most likely are fine. You could be fine. And then we get a little arrow going in that direction if you're fine, and then we can continue like that. But if we don't have adequate control, even adequate, check inhalation method and adherence. So then we actually check, are you taking this inhalation in the correct way, and are you taking it enough to get the response we actually want to get? And then adherence was an issue. Restart training, and then we see if the patient responds after we try and correct his way of taking the drug, well, his inhalation technique. If he still doesn't have adequate control, we have to see if it could be TB or heart failure. Weirdly enough, heart failure itself is also linked to asthmatic symptoms. TB and heart failure is ruled out, then initiate beclometasone inhalations. Oh, so then we only initiate beclometasone inhalations. Dose of 100 micrograms twice a day, and then even if after all of that we still have inadequate control, we increase the dose up until I think it's 800 micrograms per day. I think that's the max. And then if that didn't work and we still don't have treatment control, then we have to refer this patient to a pulmonologist. So this doctor back in the day when I was working didn't do all of this. So it was a big discussion in one of our PTC meetings. He basically started the patient on 10 milligrams of prednisone tablets, systemic glucocorticoids, and continued this patient on that treatment for a very long time until he was actually diabetic. So we fixed it by actually adhering to this flowchart here and referring him to go back to this flowchart and enlighten himself. But that's an example of prescribing error, and it all constitutes irrational drug use still. So where did he go wrong? Prescribed the wrong drugs. He didn't know actually what he was doing. Before I get to the last little part, I just wanted to show you this little slide here. It's about the cost, the life expectancy and the cost, the healthcare expenditure of the country. So I think South Africa is somewhere here, which is kind of okay-ish. No, I'm lying, it's somewhere here. Anyways, beyond the point, you can see that the capitalist system in America, you have to pay a lot of money and then you don't actually get what you want. You don't get good healthcare outcomes. It's because if you just follow the evidence, you most likely don't need that expensive drug or that expensive treatment. You can still get good outcomes with cheaper treatment, and that's not something advocated in the capital system, but it's something advocated in most other countries doing very well. And you can see a lot of them here with almost something like national health insurance are doing very well. So countries like Canada are there, Sweden are there, Switzerland are there, all of them with their what do we call it? National health insurance are doing very well, and they are all following the standard treatment guidelines or their own standard treatment guidelines and their own essential medicine list, all based off of evidence. And if you just listen to the science, you probably do much better. If you listen to not science, you probably go that direction. I just wanted to mention that. Anyways, conclusion there. You can just, yes, every treatment, every dose, every diagnosis has a reason. If you ask why and can't get the answer, so why is he getting this drug? And the answer, then you get the answer, but the answer doesn't make sense, then you're probably doing something irrational. Everything has to have a logical conclusion, a logical reason. If it doesn't, then you maybe are actually doing something irrational yourself at this very moment. So just food for thought, and I think I've given you guys enough lecture for today.